Thank you so very much for assembling back again, and thanks really to the panelists here. Perhaps after food for thought, thoughts without food. I think maybe, but it's useful that we have, at this session we are hoping is designed to be purely from a physician's perspective. I mean, we have looked at the world from what since morning we have seen what the minister had to say, what a regulator had to say, what the CEOs felt. But when we talk of healthcare and when we talk of making impactful difference on the ground, then no one better than the physician can actually tell in terms of what has changed, what is it that they see changing, and in terms of for the clinical outcome, in terms of the way adoption of various elements that go into making healthcare a better and more accessible element in our life. So the aim is therefore to get a physician's perspective on how they're seeing this the new phase of healthcare or the next era of healthcare, as they say. So, doctor, if I, doctor, if I may call you Dr. Basu, Dr. Basu, if I can begin with your thought in terms of when we talk of next era of healthcare, which is one of the elements in this. What about the current era? I mean, if you see in terms of the last few years, how do you think, what has changed? How better have you become at what you are able to do? uh, what has facilitated that? How do you look back in terms of what has changed?
Thank you very much for Financial Express for having given us this opportunity, and special thanks to Dr. Kumaran for inviting me here. The question is the whole morning we have been listening to the future of healthcare, and your question as to what difference have I seen and how it has impacted healthcare. Well, it has impacted it in a very positive way. I've been in this profession of obstetrics and gynecology for about 4 decades, more than 4 decades, and I have seen the transition from a purely clinical aspect of treating a patient to the current scenario where there is so much of technology. And I hats off to biotechnology, which has definitely made a dramatic difference and a very positive difference in the life of people. However, I think we have also reached the technology is advancing at such a fast pace. Do we also need to look at it, from a perspective, where do we go from here? How do we manage as things are today? No doubt biotechnology has helped us a lot, but we have to realize a few things. That is, it should be there are few P's: prevention, preventive, these kinds of things should be there. And I think the positive impact is there, but I think it should be very individualized and precise. And when precision, I think we'll carry on as the discussion goes.
Yeah,
But
definitely. I think we'll come back to that as well. Both precision care as well as prevention.
preventive care and
Those are crucial elements as well. Dr. Alok, if your thoughts on this in terms of what has enabled you to become better in your game, so to say.
So I had the benefit of giving this a couple of minutes of thought while you were on and sort of gaining. So what has changed? Obviously, much has changed for the good. There has been change in science. There has been change on the societal way that medicine is uh, is imbibed or consumed, and there's some disappointment too. So let me take you through the three thoughts that come to my mind. So number one, of course, medical science has moved tremendously, tremendously. I mean, you look at it from any point of view. The example of radiology in my area of oncology. So from X-rays to CT scans to MR scans to so every time you understand the disease more, you get better at treating it. You improve cure rates. You decrease disability rates. You get PET scans. You get better. So science is obviously getting better and better. And now we come to the stage where cancer is being understood more and more at its origin, which is at the gene level. Initially, we were looking at it as a tumor on a scan. Now we understand it on a gene level. And as we understand it more and more at a gene level, we are getting far better at tackling it at the gene level. And more therapeutics are coming in for that level. So certainly, there is this promise that the crude way of treating cancer with surgery or radiation would be replaced by a more precise precision way of treating cancer at its roots in the genes. Great progress in science. In terms of the delivery of care, great progress in terms of the access that patients have to medical care now. And that obviously is in terms of the patients who could not afford medical care. There's always a section which can, and but in terms of equitability, there is so much more access to medicine now because of the PMJ scheme and other schemes that are around from every state. What is disappointing, now that you asked it, it came to my mind that we have done very little in terms of prevention, and we have managed to do very little in terms of prevention. And in my specific sphere as a head and neck cancer surgeon, I have seen oral cancer increase and increase and increase, and reflected in in global statistics and Indian statistics. And the reason is quite obvious. We use oral tobacco like no other place in the world, and we have allowed that epidemic to emerge on us and its impact to come on us. So some things have done well, and some other things your eyes are opening up to what more needs to be done.
Yeah, very important actually. the some tell us that, especially during COVID, there was this phrase which used to do the rounds about science with speed. So that, in limited time you have to come out with a new vaccine and all of that. Yeah. And yes, I think over the past few years that must have also triggered some changes. But when you see as a physician, the challenge of technology adoption, the pace of the patient anxiety, and yet at the same time creating an impact, how, when you look ahead in terms of next few years, based on what has been happening, as a physician, where do you see changes, going forward? I'm not asking this as, in terms of CEO wanting to make investment, or CEO is seeing in terms of how the landscape is going to change in terms of investment opportunities, geographies, and all of that. But as a physician, pure physician, when you see, okay, like for example, in cancer care, there was earlier not much of use of AI, and because of that, maybe strokes were, the at the crucial hour, one is not able to provide adequate treatment. Maybe that is improved. Which are areas where you see greater hope now?
Uh, Thank you for this question. You see, as I see it, there is no doubt technology is helping. Medical technologies have come a long way. But I think what will always be there, and I think we need our generations to be aware of that the human interaction has to be there. Technology does not mean that every expensive test has to be offered to every individual. So there should be, when we talk about precision medicine, it is nothing more than individualized medicine, and that starts much earlier. So we still go back to the basic roots of taking a proper history, a proper family history, and the drugs that they are allergic to, what they have taken, all that kind of thing. Once we have it, we can probably incorporate it into the AI in due course. It may come up with solutions, and in fact, you'll be surprised to know that how often all the teleconsultations that I'm getting, they have an AI enabled entire data given to me. This is my test and this is what AI has recommended and what should I do. So you see, this is where the human touch will always be there. They will always ask a doctor as to how to interpret. So when we talk of precision medicine, or we talk how it is going to impact, we have to realize that the tests and technologies are there to help the doctors, they help the public, but it's not going to totally replace everything. We need more doctors who know about technology so that they can interpret it in the right way. Patients need a proper counseling. Every test is not for everybody. So with technology, we must be aware as physicians that we do not give the wrong investigation, do not give a routine investigation to everyone, though there may be times when the public or the patients may ask that so and so had a fetal echo. Shouldn't everybody be having a fetal echo or anything? No, it's not required if you don't have a history. Otherwise, if you're going to use medical technologies indiscriminately, that is going to raise the cost. So when you become, talk about precision medicine and proper individualization, which patients need which tests, and for this, a proper counseling would be required first. Otherwise, the patients, if you don't counsel them and say, "Ki, okay, you don't need it," they will think that we can be probably considered as, not taking enough care of them. So I think it is important that the human touch should be there. We must understand the technologies. We must have doctors who understand the technologies and their limitations as well, and where we can. It cannot be total automation, though automation will help us in speeding up diagnosis and treatment. Because if you have a list given by AI saying that, okay, this is what is wrong with the patient, you have saved that much of time, and you need to ask a few questions here and there just to verify, to know that what she's saying is right, he or she, and then give a suitable advice that this is what you would need. And here options are to be given to everybody. So I think, technology has definitely helped. So precision has to be there, and the preventive part also we must begin to address, in a big way. The government is working towards it, and I hope it will come. And then continuity of care should be there. So what are your question that how do we, think as a clinician's point of view? I think technology is great. It has helped us. It has, as a gynecologist, it has helped us to diagnose anomalies within the uterus. It has helped to diagnose, the genomics, the genetic defects that can be there. It has helped us to diagnose about infertility and about menopause, throughout the woman's life. And the same, I'm sure, goes for the men as well, but obviously for the women. So there are two parts to it. One is the part where there is a partnership. One is where there's the diagnostic part and then the therapeutic part. Technologies work in both aspects. And we have to look at it. What can we do as the diagnostic part? What is to be done? And the therapeutic part, what are the options? And we must make the best use of the technology in a very not regulated is not the word, I would like to say, in a very thoughtful manner as to where what should be used. Otherwise, we will have spiraling costs.
So the future of medicine, technological advancement will continue and continue, no doubt about it. Innovation is a need of society. Everybody wants to live longer and better. So certainly that's the driver for innovation, and that's happening. That will continue to happen. I recounted a few, the same will continue. But in India, especially, or world over, medicine is limited primarily by costs or resources. And world over, medicine is limited by resources. It can do more given the resources. Certainly in India, that's a very, very major thing, but that is dramatically changing. And you have seen that in the last 5 years. There's far more resources allocated to to medicine. It was said that we haven't quite reached 2.5% of GDP. We haven't, but the GDP has gone up quite dramatically, and there is more resources. So from that point of view, we are doing better. Yes.
Doctor, during the in the sessions thus far, actually since morning, we've had many say about that future is in actually there is too much of concentration happening in metros. We need to go to tier 2, tier 3 towns and cities. Technology is going to be an enabler. So कितना भी दूर हो आप कुछ भी treatment हम कर सकते हैं. As a physician, uh, uh, what what is your uh, outlook to this, that okay, that there are limited number of physicians. There is an element of inelasticity there when it comes to number of hands which can handle. In the morning I was giving the example of phlebotomist. I mean, we have a serious problem there sometimes. So how as a physician you look at this problem, because we are talking at the end of the day moving from care to impact. We do
Yeah.
need an
Okay.
impact, and it has to be all across the country, to boondocks of the country as well.
So I read somewhere, and it was true that it was a European document that a health system should obviously be quality centric, should be equitable, and should be sustainable. And from our point of view, obviously, all of these three things make sense. Uh, we can improve. We can improve on the quality centric, and we can improve on the equity. Certainly, on the equity side, we are. I mean, the issue of tier 2 and tier 3 being different is not quite an issue which should be acceptable. is not quite an issue which should be acceptable. So there will always be a tiered system. There will be a primary healthcare, there will be secondary healthcare, there will be tertiary healthcare, there will be quaternary healthcare, and it is. But secondary healthcare is something that should be accessible everywhere to everyone. And as I said, medicine has been restricted by resources in our situation, and the way forward is to find the resources to do it. It's not that we don't know how to do it; there haven't been the resources. Um, Certainly, technological advancement can make things a little bit more efficient and perhaps utilize resources better. But medicine will continue to be resource intensive. Every society has faced it. That is the reality. If you want the best, you will have to find resources for it.
Precision will come at a price.
Of
So
course,
yeah,
yes.
yeah,
Like anything in this world.
yeah.
Yes.
Yes, I totally agree with him, with you for having said that. There is one thing though, uh, when we talk, I agree that nobody should have a differential care just because they are in the primary center or they are in the tertiary center. But for this, you need two things. Number one, an awareness. So we have to work hard on the health literacy part, where technology can help us a lot, and we can disseminate the information far and wide. For example, the government has a tracking system. Any patient who's pregnant and she is tracks onto the system, then she gets a regular thing. They should eat this. This should be your diet. You are due for a vaccination, and it is followed through to 1 year of the child that the vaccination has been given, or they get reminders. So, can you imagine that technology has enabled us to implement this kind of thing? Similarly, the ASHA workers, they all have a tablet now, and they work and feed all the data on the tablet, which is all uploaded. The third thing is that which our honorable minister was talking earlier this morning is about the Abha card. That is the unique health card where all the details of an individual, the drugs that they have taken, etc., will be uploaded there, so the patient doesn't have to carry everything with themselves. It's like whether you have a digi yatra or whether you have any other modalities, so all that is going to be uploaded. So all you have to do, you give your ID, and there will be all the details about the patient there. It will save time rather than sifting through enormous number of pages, some of them bedraggled and some of them torn and half legible. So it will be all computerized. Computerized, I mean uploaded, so you can understand how greatly and beneficially technology is going to help the healthcare. So that way, what will happen is even people at the periphery, if their things are uploaded, then there should be an SOPs and systems in place that okay, till this level they are in the primary health. Now they have to be referred to the second level and to the third. So they develop this confidence that my healthcare will be taken to the highest tertiary cancer or the quaternary center when required, rather than every cough and cold ending up in a tertiary care center. So the idea is to have this continuity of care. There have been so many, I can't remember the numbers that she mentioned about the number of what she called ABHA cards. I don't know, and I'm not registered on it, but we can all be registered on it.
Yeah. One more point, actually, just want to check. See this. Uh, this issue which is often you mentioned about ASHA workers, um, uh, the challenge has always been about, we've had a lot of discussions on building a healthcare cadre, incent yeah, incentivizing and creating a healthcare cadre. As a physician, how much of what kind of innovations you think will make a difference, given that the pace at which technology is changing, given the way that patient awareness is increased. uh, the old model of having a paramedic trained, ये टाइम पे blood लेना है, ये टाइम पे ये करना है, वो, compared to dealing with a paramedic dealing with a patient who's aware, who knows which antibiotic to take for what, and why so much has been prescribed, why this is being done, and why now, why not post meal. Your view in terms of when looking at the nuances of healthcare cadre development, when you're talking of impact as a physician, where do you think emphasis should be now?
You brought up an interesting aspect about patients being aware and questioning healthcare decisions. And there are many aspects to this. I used to work in the UK once, and I was surprised to find that a far more educated and aware population was far more accepting of physician decisions than here. So many reasons for it. A, of course, they don't have a choice. You can't see five doctors like we can, and that is not necessarily a good thing for us. But the reason they have support, they have confidence in the one doctor they see is because the system is very well regulated, and the doctors guild or the medical council or whatever we call it, but the system is such that it is well regulated, so doctors have to be of a certain standard. So society respects the knowledge base that the doctor has and doesn't question it for two reasons. One, anybody who's certified is up to a certain level. B, they are not really given the choice. After all, the state is paying for it, and the state doesn't pay for you to see five doctors. That is how it is. So there is regulation. So there was far more comfort in patients accepting what it was, and it was a far more. Um, so here, sometimes it does happen, not sometimes. Sometimes it does happen that there is a confrontationist attitude to medicine. It is ultimately a cooperative way. You're both seeking to find the next way forward, the best way forward, and confrontation is not necessarily the best way. I'm not saying it happens every time, but there is that, as you said, aware patient asking, why not this antibiotic? Why this antibiotic? So just like we see lawyers, we see chartered accountants and generally accept their decisions. You need to realize that if you see a professional, you have to accept their decision. Obviously, you should have confidence in the profession, and obviously, the profession should be better regulated, and it is. So there is that aspect to something. It is not innovation; it's just doing things right as they should be done even today. Um, I don't know. That's it. Yeah. Any other thoughts? Yes.
Last bit actually,
Yes.
as a if you look in terms of the current priority, what is engaging your mind? Say if you were to have a conversation a year from now, what is the thing you think you would want accomplished as a physician looking at impactful outcomes? What is the one thing that you think we need to kind of work a bit more on, where it can then make a difference? This is my last point.
So
Both.
work in progress, like in most of the things, work in progress. There is work in progress on the science level. Science in medicine is moving rapidly, rapidly. In oncology, I see it changing very dramatically. We're at the threshold of understanding, individualizing, personalizing each cancer in terms of the cellular changes, the DNA changes that are happening. MedGenome was here. They told us how it's become cheaper and cheaper to do these tests, and we are doing them better and better. This will explode. Next 5 years, every cancer would have totally known where it originated, how many genes were wrong, and we will have more interventions. So science is exploding, no doubt on that one. The other aspect that I touched on and ma'am touched on was again about making
No, I
healthcare accessible. That is happening.
I meant, perhaps not in so many words, essentially meant in terms of upskilling. Not
Upscaling.
that you need upskilling, but one always needs, isn't it? I mean, so that given the technology where you're kind of outsourcing thinking to a machine,
Hmm.
so how do you therefore in an environment like this, where do you see that you need to upskill? Where is it that as a physician today, uh, looking for impactful outcomes? uh, is your thought going on that? I mean, is there any area where you think I need to do a bit more? I mean, by I here, I mean generally, until unless you want to take a specific case, and that's my conclusion.
Any thoughts, ma'am?
Yeah, please.
A difficult question. Machines may be doing our thinking, but as has been said, there is intelligence, there is knowledge, there is intelligence, there is foresight, there is wisdom. So machines haven't quite reached foresight and wisdom yet. Foresight they're getting to. Maybe we will.
So
Uh,
any new technology, any new aspect that you think physicians should be now upskilling themselves with, or do you think that just reading the journals, attending conferences is going to help?
I'm at a loss. I'm at a loss.
I think
Maybe I
yeah.
can get advice. आप
No,
बताओ. हाँ, हाँ.
no. I think technology is there,
Yeah.
but the professionals need to be trained in technology, because any machine is as good as the person behind the machine. So whenever we are talking about technology or a particular test or a genomic test or any kind of test, we first need to understand the implications, the limitations, and how effective they are going to be, what are they going to achieve. Unless we understand this, we cannot communicate this to our patients. And if the patients, then they have the choice whether they want to go for this advanced genetic test like chorionic amniocentesis or chorionic villus biopsy, etc. Unless we tell them about the technology and the details, so we have to be first. So we need to train professionals in technologies as well as train them in communication and how to document all that communication. So their technology may help us. That, in fact, I think there is probably one platform where as you are dictating or taking the history, it probably writes down everything. So that speeds up we don't want to be always behind a screen, so that the time interaction with the patient is reduced. We need to be interacting with the patient directly, and all the technology and etc should be there to help us out and support us and give us further answers to questions which may be in our mind. So technology can keep on advancing, but at the same time we need to train professionals, whether, as you said, about the phlebotomist or etc, because we cannot have a scanner looking at a vein everywhere in the peripheral remote area. That is going to increase the cost. So we have to look at the cost, equity, etc. So we look at the clinical relevance of any investigation. The continuity of care should be there. The communication, and I cannot stress enough on communication because I'm so particular.
And you've written also on that. The reason and I want to qualify that, the reason I was asking this question is, for example, if you take a specific case, like for example in gynecology, there are these consanguineous marriages which are there, close relative marriages. पहले क्या था कि okay, there is a rare disease, कुछ कर नहीं सकते हम. That is, the child will have this much mortality chances. Today there is gene editing possibility. Today there is a possibility of stem cells. So, how much areas seems to be opening up in terms of a doctor need to be skilled in that to be able to guide the patient. Maybe the doctor is not able to do gene editing at that, but at least maybe this is one area in which you can explore. So, I meant from that perspective, when we creating impact, how to therefore guide patients in the right on the right path. So I don't
So
know.
because it's related to my specialty, I will just say this, that you're talking about gene editing, you're talking about these cases of consanguineous marriages, etc. Precision medicine, if you go back a little, it basically starts right from the history, and then you pick up patients who need what. Gene editing, etc., is still not in a position where it can be applied across the board. First of all, we need to have a database within our country which tells us how many of them are actually affected, and then work out. For example, when I was working in the UK, everybody was not given down screening at that time. And they said, if you have a history, if you are above the age of this, and there are certain criteria that were laid down, that only then will you have downs testing. And then gradually, as you learn more, you add more. So medicine and technologies are going to help us to give more information whereby we can implement them, but they have to be done at a very judiciously. They have to be implemented, and we hope that the people who are working on all these technologies can work on a model which makes it accessible to most people and reduce the costs.
Dr. Alok, uh, the lady doctor has allowed you to have the last word.
You brought up a very interesting thing. Certainly, the thought was evoked by this one where you said that. So yes, errors of congenital errors and that kind of thing. Today, you can do testing in the fetus itself and often find out if a child has a problem or not. You can do gene testing in the fetus and find out and take appropriate measures. And you hear that in the court now and then. And yes, gene editing is futuristic, but has started to happen. There have been a few things that have happened and have made a difference. Um, Certainly, the next couple of decades, I would expect this to be in place. Yes, but a couple of decades, yes. Hmm.
So thanks so much. I think time's up, and I wish I could continue, but thanks.